Welcome everyone. My name is Anita Pfeffer, and the title of my PhD thesis is Evaluation of Oncology Treatment Approaches and Clinician Practices for Safety, Efficacy, and Adherence. I'm a medical doctor and a PhD student at the Pediatric Center 203 department at Semmelweis University. My mission is to improve the survival and life quality of oncological patients. In order to achieve this, my mission is to identify the least harmful and most effective therapeutical opportunities for these patients. Currently, I have two ongoing projects. In my first project, I investigate the effectiveness and safety of available therapies in adrenocortical carcinoma, and in my second project, I focus on the efficacy and safety of growth hormone therapy for pediatric brain tumor survivals. Let me introduce my first project with the title of Comparing the Effectiveness and Safety of Available Therapies in Adrenocortical Carcinoma. We are working on a systematic review and meta-analysis in this topic. Adrenocortical carcinoma is a rare malignancy with poor prognosis. Regarding the treatment protocol, a uniform guideline is not available, especially in childhood and in advanced stages. That's the reason why my aim is to investigate the effectiveness and safety of additional therapeutical modalities. 4 different stages of adrenocortical carcinoma can be distinguished according to the severity of the disease. As you can see, the gold standard therapy in all stages is surgery, but from stage 2, we can choose between different adjuvant therapeutical modalities. But there is a lack of knowledge whether each adjuvant therapeutical modality contributes to recurrence-free survival and overall survival. My clinical question is which adjuvant therapeutic modality provides the best survival and lowest number of side effects. I use the PICO framework, in which population is patients with adrenocortical carcinoma, intervention additional adjuvant therapy, the comparison no additional adjuvant therapy, and the outcomes mortality and side effects. My hypothesis is that all types of additional adjuvant therapies lead to higher risk of developing side effects, but increase survival rate in adrenocortical carcinoma. I conducted the systematic search in the middle of November, and I found more than 17,000 hits. After the whole selection process, I had 81 eligible full texts for analysis. Let me show you my most important results. On the first forest plot, we investigated the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without additional mitotan treatment. Hazard ratio is a measure used in survival analysis to quantify the relative risk of an event occurring in one group compared to another over time. It represents the ratio of the hazard rates between the two groups. We included 40 retrospective cohort studies in our analysis, and we divided them into 3 different subgroups based on the stage of the disease. We investigated separately the overall survival in patients with stage 1-4, in patients with stage 1-3, and in patients with recurrent disease. The importance of this subgroup analysis is that the effectiveness of the treatment can be highly influenced by the extent of the disease. The I-square number is 55%, meaning the level of heterogeneity is moderate. The measure of effect is adjusted hazard ratio. If the hazard ratio is more than 1, so it is on the right side of the level of no effect, it indicates that the intervention group has higher risk for death compared to the control group. If the hazard ratio is less than 1, so it is on the left side of the level of no effect, it means that the intervention, so in that case additional mitotan treatment, reduces the risk of mortality. The overall hazard ratio is 0.53, which indicates that additional mitotan treatment reduces the risk of death by 47%. This result is clinically relevant and statistically significant. We got similar results based on our subgroup analysis, and we found that additional mitotan treatment significantly reduces the risk of death in patients with stage 1-4 and in patients with stage 1-3 disease. On the second forest plot, we examined the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without additional radiotherapy. We included several retrospective cohort studies in our analysis. The I-square number is 30%, meaning the level of heterogeneity is low. The measure of effect is adjusted hazard ratio. The overall hazard ratio is 0.72, which means that additional radiotherapy reduces the risk of mortality by 28%. This result is clinically relevant, but not statistically significant. However, we found that additional radiotherapy significantly reduces the risk of death in patients with localized adrenocortical carcinoma. On the third forest plot, we examined the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without cytotoxic chemotherapy. We included 3 retrospective cohort studies in our analysis. The I-square number is 64%, meaning the level of heterogeneity is high, which can be caused by the heterogeneous population of the included studies. The measure of effect is adjusted hazard ratio. The overall hazard ratio is 0.61, which shows that cytotoxic chemotherapy seems to reduce the risk of death. However, there is a wide confidence interval caused by the third outlier study, which must be taken into consideration when discussing this result. Our meta-analyses have a lot of strengths, such as the stage-based subgroup analysis, the high number of participants, and the complex and comprehensive analysis. To highlight limitations, most of the included studies are non-randomized studies, there is a high heterogeneity of patient characteristics, and there are missing adjustments for important variables in some studies. In conclusion, we can say that mitotan treatment and radiotherapy prolong survival in both localized and advanced stages of adrenocortical carcinoma. The clinical implication of our finding is that for patients with adrenocortical carcinoma in both localized and advanced stages, mitotan treatment and radiotherapy should be considered. Further research is necessary to improve the evaluation of the efficacy of cytotoxic chemotherapy, analyze the effectiveness of the different treatment approaches across different stages and among pediatric patients, and more RCTs are needed to minimize the selection bias. Here you can see the progress of my first project. I finished the article draft and I sent to internal review my manuscript this week. And now let me tell you some details about my second project with the title of Efficacy and Safety of Growth Hormone Therapy for Pediatric Brain Tumor Survivals based on real-world data. We are planning to do an international survey in this topic. Brain tumors are the most common solid pediatric malignancies. Thanks to the improvement of the treatment opportunities, the 5-year overall survival rate is over 80% in these patients. However, as a result of oncological treatments, we often have to reckon with serious endocrine side effects. One of the most common is growth hormone deficiency, which can be caused by the hypothalamic pituitary dysfunction from the tumor itself, surgical resection, or radiotherapy as well. Now, there are well-developed international guidelines for initiation and use of growth hormone replacement. Despite this, several studies show that in clinical practice, the treatment of the affected patients, considering some important aspects, is not carried out in accordance with the current guidelines. That's the reason why my aim is to evaluate the management of growth hormone deficiency in the clinical practice and investigate the effect of the different treatment approaches for safety and efficacy. My clinical question is, how does the different management of growth hormone replacement influence the growth and the risk of recurrences and secondary malignancies in pediatric brain tumor survivals? I would like to use the PICO framework, in which population will be pediatric brain tumor survivals, intervention and comparison, the different management of growth hormone replacement, primary outcomes, recurrent disease and secondary malignancy, and the secondary outcomes, shortfall of height and catch-up growth. My hypothesis is that management of growth hormone replacement, according to the international guidelines, provides the best catch-up growth and lowest rate of recurrent tumors and secondary malignancies. The clinical implication is for patients, improved quality of life, for clinicians, optimizing growth hormone therapy, and for policymakers, maximize the potential clinical improvement. To summarize, as I mentioned earlier, my most important aim is to improve the survival and life quality of oncological patients by identifying the least harmful and most effective therapeutical opportunities for them. With these 2 researches, I would like to contribute to achieving this. I would like to finish my presentation with the words of Albert Szent-Györgyi, who said that research is to see what everybody else has seen and to think what nobody else has thought. Thank you for your attention.
Congratulations for the very interesting presentation. 2 things. For research implications, you said that in the case of adrenocortical carcinomas, randomized controlled clinical trials could be or should be done. Is it possible when actually the treatments prolong life? So how feasible is that?
Thank you for your question. So the most important reason why it is hard to organize the randomized control trial is the low number of the patients. So it's a very, very rare disease. 2 per 1 million patients is affected, but there are 2 randomized control trials. One investigates the effect of mitotan treatment in low-risk patients, and the other compared 2 different chemotherapy regimens in these patients.
I see. So it is still done.
Yes.
And there is another thing in your second topic or a project. Are there any implications in the literature that growth hormone therapy may have side effects like increasing glucose, abnormal glucose tolerance, or maybe some other side effect for slight overdose or?
Thank you for your question. In a very rare cases, it can cause side effects, such as liver problems, for example. But it's a very rare situation that it can have similar
it's
side
quite
effects.
well managed then.
Yes.
Thank you.
My question is, what's the criteria for the growth hormone replacement in the brain tumor survivors? Is there an international protocol, like you are under a certain percentile and then you get it, or how is that?
Yes, thank you for your question. So based on the current guidelines, for those patients who have benign brain tumors, such as craniopharyngioma, it can be started 3 months after the surgical removal of the tumor if the patient has growth impairment. So if their growth is under the -2 standard deviation. And it can be started for patients with malignant brain tumors, such as medulloblastoma or ependymoma, 1 year after achieving tumor remission in these patients.